For fetal monitoring, the first thing we want to know is if we have a normal baseline. Okay, and I know that's not your question, but it'll come back to that. So what's the normal baseline for fetus?
It's 110 to 160.
110 to 160. And when we look at the tracing, we're looking at how long, like where the squiggly line is hanging out most of the time. And that's our baseline. Okay. We want it to be between 110 and 160. We also look at something called variability. How much does the line squiggle? Okay. And the squiggliness of the line gives us an indication of how the baby's doing. All right. So if you have a line that's just got tiny squiggles, less than 5 beats of variation, that's minimal variability. Minimal variability might be fine. Babies that are sleeping can have this little minimal line, but also that can be a sign that the baby's becoming hypoxic. So we don't totally know when you have minimal variability. We're not totally sure the baby's fine. We're not necessarily worried, but we're watching it closely. If we have good squiggles where the variations are between 5 and 25 beats around the baseline, that's moderate variability. That's really reassuring. Okay. So, and there's a couple other variations to that too, but those are the two main ones that you might see is minimal and moderate on the variability. Okay. Then we get to accelerations and decelerations. If the heart increases more than 15 beats above the baseline, and it lasts for longer than 15 seconds, that is an acceleration. With an acceleration, that is a good finding. That's another thing that babies can't do if they're not well oxygenated. So if you have an acceleration, I'm trying to see if I can show you a picture. If you have, I'm going to find, I have a PowerPoint that has like better pictures. I'm going to just grab them while I'm talking to you. If you have accelerations on the tracing, that's very reassuring. So if you have moderate variability and accelerations, that baby is doing really well. Okay, we know that baby is well oxygenated. We don't have any concerns, right? If your baby is having decreases, that's where the decreases get a little bit confusing, a little bit complicated. But if we're having decelerations, then we're going to look at what kind of decelerations that we're having. And that's going to help us know how worried we are and what we need to do about it. So I'm just going to share my screen for a second, just because I have in this one PowerPoint, this isn't one I use for class, but it has some good pictures in it of what I'm talking about. So this one for variability is those little fluctuations around the baseline. And you see this line right here is not very, it's kind of flat, right? There's not big variations here. That's minimal variability. That's the baby that might be taking a nap, but also might be hypoxic. I'm not sure. I also might have given mom fentanyl and the baby's also kind of sleepy. All right. Moderate variability, this is the next one I talked about. See how much more squiggly this line is? Okay, that's good. All right, and then accelerations. So here's accelerations. I'm going to zoom in on this picture. So when we look at the tracings, we're looking at, and you guys don't have to read tracings. Like you won't have to see a picture of a tracing and go, oh, that's moderate variability. But just so that you understand what we're talking about when we say more than 15 and more than whatever, this is the little graph we look at. And the graph has in the lines moving up, they're each 10. And then on the boxes moving side to side, they're each 10. So 10 beats going up and 10 seconds each going across. For an acceleration to count, it needs to go up by at least 15 beats and last at least 15 seconds. So if we look at this hill right here, this increase, this is our baseline. This is where the heart rate's hanging out the most. And then we count 10, 20, 30. It went up by 30 beats. And then we count across 10, 20, 30, 40, 50 seconds. It lasts 50 seconds. So this is an acceleration.
So that's good,
Accelerations are
right?
really good. They're really good. I'm so excited when I see accelerations on a tracing because I know that baby is neurologically intact and is well oxygenated. Okay, the whole point of fetal monitoring is to determine if our baby is oxygenated. A tracing like this right here, where we have a normal baseline, because if I zoom in and look, this baseline, here's 120, 130, 140. So this baseline's at about 140, so it's a normal baseline, moderate variability, accelerations. This is reassuring that this baby is doing well. Okay. Now, when we get into decreases, let's look first at early decelerations. Early decelerations mirror the contraction. So when the contraction happens, and you see the blue shaded area in this picture, okay, you can see where the contraction starts down here, and you can see where the contraction ends. And then up here is the fetal heart tracing, and you can see when the contraction started, the fetal heart rate went down. And then when it comes back up to the baseline here, that's also right when the contraction's ending. So these are happening at the same time. They're mirroring each other. This happens when there's pressure on the baby's head during the contraction. So this is not something that will cause hypoxia for our baby. This isn't concerning. We just monitor this. This is actually probably a sign of progress that the baby's coming down further in the birth canal. And so we call these early decelerations, even though they're really kind of on time. All right. And you can see in this picture, all three of these, they happen exactly the same. They're mirroring each other. This is head compression. This is normal. Okay. Let's look at late decelerations next. These are the ones we worry about the most. Okay. So down on the bottom of the graph, you see where the contractions are. And then up here, you can see the heart rate, and then you can see where it goes down. And so the shaded area is shading where the deceleration is, so you can follow it down and see how it lines up with the contraction. And you can see that this deceleration started after the contraction was already at its peak. And this deceleration didn't come back to baseline until well after the contraction had ended. These, if the word after is in your sentence, it's a late deceleration. It happens after the contraction starts and it ends after the contraction ends. And this one, guys, is the most worrisome. All right. This is when we look at veal chop, this is a sign of placental insufficiency, or you might also see it written as uteroplacental insufficiency, where we're just not getting enough oxygenated blood through the uterus to the placenta to give the baby the oxygen it needs. And so this drives hypoxia for the baby. This is dangerous. Okay, these are late decelerations. The other type of deceleration we have are variable decelerations. And the word variable sounds like variability, which is what we talked about with the squiggly line, but it's different. Okay. Variable is because the timing of these are variable. It doesn't matter. The timing for variable decelerations does not matter how it times with a contraction because the problem that's causing it is not the contraction. Okay, the other ones with early, we're getting head compression during contraction. With late, we're not getting good blood flow during the contraction. But with variables, the problem is cord compression. And so it's possible that the contraction caused the pressure on the cord. But it's also possible the baby squeezing his cord or he rolled over on it or something like that, and that's what caused it. And with variable decelerations, they have an abrupt onset. They happen quickly. So if you see keywords that say like sudden or abrupt, you see how this drops really fast? And then it comes back to the baseline really fast as soon as the pressure relieves off the cord. And so it makes a kind of V shape. And in this one, it looks like it times with the contraction. This one looks like it times with the contraction. This one doesn't. See, the timing might not be related to the contraction at all. It's really only caused by whatever is putting pressure on the cord. All right. These are not as worrisome as late decelerations because as soon as the pressure relieves from the cord, they're going to start getting that good oxygenated blood flow again. They're getting oxygenated blood from the placenta. There was just an interruption in the blood flow while there was pressure on the cord. So these ones, we still want to kind of try to get the pressure off the cord. So a good first thing to do is to move the mom to see if we can shift the baby. All right. But this isn't going to be the one that I'm worried about causing hypoxia for. Okay, so that's what they all look like. That's what they all do. Then we think about veal chop. So with veal chop, the word veal, you write it in a line. And then the word chop, you write it in a line next to it. And then in my graph, I have the word mine next to that because that reminds us what needs to happen or what we should do. Okay, so for V are caused by variable decelerations. And the first letter of chop is a C, so that reminds us that it's cord compression. All right, variable decelerations caused by cord compression, we should move them up. Okay. And then in the capitals here, you can see the type of words you might see that would remind you that it's a variable deceleration. So if the decrease has an abrupt onset, that's probably a variable. The E of veal chop is early decelerations. Early decelerations mirror or happen at the same time as a contraction. They're caused by head compression. And for the mine part of what we should do, intervention isn't needed. So if you have something that is a normal finding, early decelerations are normal, what would be the priority nursing intervention for an early deceleration?
Nothing. We just kind of encourage the mom to keep going, I guess.
Yep, and document the finding.
Yes, of
I
course.
remember when I was in nursing school and whenever I saw document the finding, I was always so stuck on that. I'm like, of course I need to document this, but that's not the priority unless there isn't another priority. If there isn't another priority, all you need to do is document it. Okay, so for early decelerations, reassure the parents, let them know that their baby's doing well, document the finding. Okay, so intervention's not needed. Accelerations, we looked at that. Those are those increases that are at least 15 beats and last at least 15 seconds. And in parentheses, I put in here because that it's if they're over 32 weeks, because if the baby's less than 32 weeks, then in order to meet criteria for an acceleration, it only needs to be 10 beats by 10 beats. But I don't necessarily think you guys get asked that. They give you that information so you know that if the baby is younger, if it's less than 32 weeks, it doesn't have to do 15 by 15, it can do 10 by 10. But any baby over 32 weeks is 15 by 15. So those are the numbers to know. Okay. This is a sign of oxygenation. Remember, if we're having accelerations, that's great. So there's nothing to do. So what do? We document the finding or reassure the parents or whatever answer says this is normal, this is fine. Okay. Late decelerations. That's this guy that looks really bad, right? Because it happens after the contraction starts and comes back to baseline after the contraction ends. Late decelerations have that keyword of after. In veal chop, it's the P for placental insufficiency. These are dangerous for the baby. This is going to drive hypoxia. So the main things we think about for this is how do we perfuse the placenta and what could be happening with her that is affecting her perfusion to the placenta. So it could be her position. Remember supine hypotension, if they're on their back, the baby's putting pressure on the vena cava, it causes her blood pressure to go down and she doesn't perfuse her placenta well. So that can cause late decelerations, that can cause a hypoxic baby, and that's why we teach moms to turn on their side. Or even if we lay them on their back to measure their fundal height and they don't feel well, we just quickly are getting them off their back. We don't really want them laying on their back, okay? So consider position. And position's a good first thing to do for either variable or late because it's quick, it's easy, it's non-invasive. So if I move the mom on variable, I'm taking pressure off the cord. If I move the mom for late, maybe I'm perfusing the placenta better. It could be blood pressure. If her blood pressure is low, we're not perfusing the placenta well. And does anybody know something that we do purposefully to women in labor that can cause them to become hypotensive? Any idea? She will ask for it.
Making the epidural.
The epidural. Okay. So an epidural can cause that blood pressure to go down. And if the blood pressure goes down, then it affects perfusion to the placenta and can cause late decelerations. And then contractions can also cause late decelerations because every time, I have it in here. I think I have a picture of this. Every time that the uterus contracts, during the peak of the contraction, there's no blood flow coming to the placenta. All right. And so if we don't have normal blood, we have normal blood flow between contractions. And then as the contractions building, we have less. And then we have no blood flow during the peak. And then we have less. And then we're back to normal again. If these contractions are right on top of each other, we're not getting good blood flow in between the contractions to exchange out the waste and to bring in good oxygenated blood to help sustain the baby during the contraction. So if she's having too many contractions, they're too close together, that also can cause her to have late decelerations. And so that's another thing that can cause placental insufficiency. So when we think about that, then to think about what we need to do, I like the acronym POINT because position is first. Position's a good first thing to do. Okay, change your position and see if we get pressure off the vena cava, if we get better blood flow to the placenta. Oxygen is always a choice, and we still teach it, and it still shows up on NCLEX, but in practice, oxygen is not the first priority. And let me tell you why. If I'm not getting good blood flow through to the placenta, it does not matter how oxygenated I make that blood because it's not getting through the placenta to the baby anyway. So oxygen's really more to make the nurse feel better, like she's doing something. All right. And it is helpful if mom is hypoxic. If she has a condition that's causing her oxygen saturation to be low, oxygen is a great idea. But it's not really a priority for this. But if there's not any other choices that fit what your patient needs, you could always select oxygen. But I wouldn't pick it as a first choice. So position for sure. IV fluid. If her blood pressure is low, let's give her some IV fluid to support her blood pressure. And that's even what we do with epidurals before we give the epidural to help support the blood pressures. We give a fluid bolus. Okay. The N is for notify. If I'm having late decelerations, we need to notify the provider. They might need to order tocolytics, which is the next thing on our list to slow contractions down. They might need to consider doing a C-section because this baby is not getting good oxygen. The baby is showing signs of hypoxia with these late decelerations. And so notify the provider. And then the T is for tocolytics. Tocolytics are medications that slow contractions down. We can also use T to turn off the oxytocin. If we're giving her oxytocin or pitocin to augment her labor and her contractions are too close together and we're having late decelerations, turn it off. Okay. Anybody know what the tocolytic of choice is here? What we could use for this patient right now to help slow her contractions down?
Is it terbutaline?
Yeah, good. It's terbutaline. All right. So we can give her terbutaline and it would slow her contractions down. So the good first thing to do is position change. Then we can do IV fluid. We can turn off the Pitocin if we need to. We can give terbutaline if we need to, and we need the doctor looped in case they need to do a C-section.